Hello everyone. On this video we're going to be talking about the physiology of the cardiovascular system, so let's dive in. Your objectives are going to be to define a few things and explain what information we can get from an ECG and discuss special circulation, and we're going to go over all of that now. So cardiac output is just the amount of blood that's pumped out by the heart, by each side of the heart, in 1 minute. And it's a product of heart rate and stroke volume. Heart rate is something we're all very familiar with. It's the number of beats that your heart takes per minute. The stroke volume is the volume or actual amount of blood that's being pumped out by the ventricles with each heartbeat. So to calculate the cardiac output for somebody who has a heart rate of 75 beats per minute and a stroke volume of 70 milliliters per beat, we would just multiply those two numbers together. And it gives us 5.25 liters per minute. Really what it would end up giving us is this number of 5,250 milliliters per minute, but 1,000 milliliters is the same thing as 1 liter. Now your cardiac output is going to be different based on the needs of your body. So it's different per individual. It's different based on whether you're sleeping or you're eating or you're exercising. And the way we regulate it is in two ways. We can regulate our stroke volume or we can regulate our actual heart rate itself. So the stroke volume is usually determined by how much blood the ventricles get from the atria. So how much blood is actually in the heart for us to pump out. More blood means the ventricles have to pump harder to get it all out. Now, in heart rate, we're going to see that the sympathetic nervous system is going to play a huge role. We're going to, if we're in a fight or flight or freeze response, that sympathetic response, it's going to increase our heart rate so that way we have more blood circulating around our body to get to our tissues so that they have enough oxygen to be able to explode and run away or to see the threat as best as possible. The parasympathetic control using our vagus nerve is going to slow and steady our heart rate. So this is part of the rest and digest phase. We even have drugs that can affect the heart rate, like epinephrine. We can inject you with epinephrine and increase your heart rate. We can affect our heart rate because we have an imbalance in electrolytes. So if you are dehydrated or if you're not getting enough electrolytes in your diet and you're an athlete, this can affect your heart drastically. And then also temperature is going to change your heart rate. So if the temperature increases, you're actually going to have a faster heart rate. So how does the heart beat? The heart has what we call an intrinsic conduction system, meaning it has a built-in system that regulates the heartbeat. So it's partially controlled by our nervous system, but this is also why you can cut a heart out and it can still temporarily beat because it has its own internal pacemaking activities. Kind of like this GIF right here, you can see that the heart, even though it's cut out, is still beating in that person's hand. So how does this internal regulation system work? How does the heart beat? Well, it all starts at this SA node, the sinoatrial node, and it is in the right atrium. It's a tiny group of cells that they're going to essentially be the pacemaker of the heart itself. They're going to start the whole contraction process when they're depolarized, kind of similar to what we talked about with the neuron. And this initial input is then going to get sent to the AV node. That AV node does not get triggered right away. There's a brief delay so that way our atrium can fill up with blood before we actually then contract the atria to push all that blood into the ventricle. So it's got a tiny bit of a delay for that reason. Now once the AV node has been activated, it's going to pass its depolarization signal down this bundle of His, or the AV bundle, and through what are called Purkinje fibers down in the bottom of our ventricles here. And those Purkinje fibers, when they are activated, they're going to cause the ventricles to contract. And the contraction starts out at the bottom and then works its way up the heart muscle. So it's squeezing from the bottom up, because all of the veins or all of the arteries that are taking our blood out of the heart aren't on the bottom, they're up on the top. So we need to be able to get that blood up and out of the heart. So there's something called a heart block, where you have damage to that AV node, and it causes the ventricles to not beat at the pace that they're supposed to. They're going to be a little bit naturally slower than the atrial rate. So we always want these to be in conjunction with each other. We want the whole heart to be talking to itself, and when it doesn't, you can have bad things happen. Sometimes we can end up with fibrillation. Most often we get this when we have an ischemia or a lack of blood flow to the heart itself. And fibrillation is just rapid, uncoordinated shuddering of the heart muscle. Basically, your heart can't pump properly because it's constantly twitching, like you can see here. Now, this is a fibrillation over time. So this one is not in real time. Now, this is the type of problem with your heart that we can correct with those defibrillators. We give them a shock, we get the AV node beating back in the same rhythm with the SA node, and your heart goes back to normal. You can also have what's called tachycardia. Now, this isn't necessarily a problem. Our heart rate will naturally go up in response to certain situations. We need our heart rate to go up to cope with the demands of exercise. We like our heart rate to go down when we're relaxing, so we're not wasting as much energy. So tachycardia is that fast, rapid heart rate. It's defined as 100 beats per minute or more. And like I said, this often happens during exertion or exercise. Now, it's not a problem unless you keep this incredibly high heart rate up for a long period of time. And we're talking a very long period of time. It can end up leading to a fibrillation. Bradycardia is a slower than normal heart rate, less than 60 beats per minute. Now, this is a little bit of an issue for us, because you're going to run into some top athletes who will have resting heart rates lower than 60 beats per minute. Now, they're not unhealthy. In fact, their heart is so well regulated and it's so strong that they don't have to beat as often in order to get the blood pumped around the body. So the world record for lowest heart rate was 26 beats per minute. The average heart rate, to give you an idea, is around 70 to 75 beats per minute. So don't think that just because somebody's heart rate is low that it's always a problem. You have to get a good history and find out, are they an athlete? Now, the cardiac cycle is going to discuss how the heart actually contracts and relaxes. The atria are going to contract simultaneously. So this is a normal, healthy heart that we're talking about for all of this. Both of the top atria are going to contract and squeeze all that blood inside there into the ventricles. As the atria begin to relax, then the ventricles will contract. So systole is the term we use to say a contraction is occurring, and diastole is when that relaxation is occurring. Now, these two terms, we almost always use them when we're referring to the ventricles, not when we're referring to the atria, because the ventricles are the ones that we tend to really care about a lot more. They're the ones that have to send that blood to the lungs or all around the whole body. So if they're not working properly, the blood is not leaving the heart properly. The whole cardiac cycle, the complete events of one heartbeat, last about 0.8 seconds on average. So let's talk about the three main periods of the cardiac cycle. The first one is mid to late diastole. And this is going to start with the heart in complete relaxation. We're going to have blood passively flowing into the atria. or from the atria into the ventricles, excuse me, and it's going to end with those atria contracting forcefully to get all that blood that's remaining in there pressed into those ventricles. We want to get all the blood out of the atria into the ventricles. This is going to mean that our AV valves have to open, our atrioventricular valves, the ones between the atria and the ventricles. In our second period, we have ventricular systole. We're going to have contraction of those ventricles. The AV valves are going to close due to the increasing pressure in the ventricles. We don't want any blood flowing back into the atria. And then we're going to cause that contraction, and the blood will start to leave the heart through the semilunar valves. At this time, the atria are relaxed and they're actually being filled up with blood again. And finally, we have the early diastole. This is when the ventricles are relaxing. The semilunar valves are going to close so blood doesn't flow back into the ventricles. And for a brief moment, the ventricles are completely closed off to everything else. All of our valves are closed. And at the end, in this point, you're going to hear that dub sound of the heartbeat. I forgot to mention, when we're in ventricular systole, at the start of it, we're going to hear that lub sound of the AV valves closing. Then when all of our semilunar valves close, we'll hear that dub sound, and that's what makes that heartbeat sound that we typically hear. As I just said, the cardiac cycle has two, not tau, distinctive heart sounds, the lub and the dub. And there's a slight pause between both as those ventricles fill up, or as those ventricles contract and push the blood out of the heart. So you hear a lubbed up, pause, lubbed up, except it's a lot faster than that. So the first sound, as I said, is caused by the AV valves closing, the atrioventricular valves. The blood has gone from my atria into my ventricle, and now that valve needs to close, so when my ventricles contract, no blood goes back into the atria. The second sound, after I have squeezed all of my blood out of the ventricles, those semilunar valves are going to close, and that way blood can't re-enter the heart. You have a couple videos that are also posted to our topic page, and they're going to show you or let you listen to normal heart sounds and then compare them to a bunch of different types of murmurs. And murmurs are just abnormal or unusual heart sounds. And they're caused because the blood is not flowing properly through those valves. There's some kind of malfunction in the valves, or maybe your valves aren't formed properly, and the blood is kind of leaking through instead of being closed off the way it's supposed to be. These tend to be much more common in young people, like children and the elderly, because their heart walls are a little more thin than adult heart walls are. Adults with murmurs, usually that's when you know something is seriously going on. And the murmurs will often sound like a whooshing or a swishing sound because the blood is not being blocked properly. You're actually going to hear the blood moving and whooshing through those valves that are not completely closed. We can track this whole process with something called an electrocardiogram. It's a recording of these electrical impulses as they're being sent through the heart. And there's three main waves. The first wave is the P wave, and it's a smaller wave. It's not one of the biggest waves. And this is made when the SA node fires. So this is when that pacemaker node of the heart fires. Then you have the gigantic one in the middle, the QRS complex. And this large wave is what happens when the ventricles depolarize. So when the ventricles begin to start their contraction process. And this T wave at the very end, another one of the smaller waves, is going to occur when the ventricles repolarize, when they're relaxing and resetting to do another contraction. There's also atrial repolarization, where the atria tend to relax and reset, but it's such a small little wave that it gets hidden by that QRS complex. We don't see it because the ventricles will overpower what's going on with that atria. Now your pulse is caused by pressure waves as the heart beats. So your blood is a fluid, and just like if you go to the pool and you try to make a wave in the pool, you can see the wave propagating through the liquid. The same thing is happening in your blood. As your heart beats, it's causing a pressure wave to move through that fluid of your blood, and we can feel it in our arteries. We can only feel it in our arteries, not our veins. So this is where we take our vital signs. We find one of those arteries, we put our fingers on them, and we listen, or we feel, excuse me, for those pressure waves as they move through those arteries. Now, interesting thing, you don't want to use your thumb to take a pulse from anybody, because your thumb has an artery in it that has a detectable pulse. So sometimes if you're trying to feel for somebody's pulse with your thumb, you'll actually just be feeling your own pulse. So always use your index and middle finger to take the pulse of somebody else. Now, blood pressure is just the pressure that the blood is exerting on the walls of the vessels. So the blood is pushing back out against the vessels themselves. It's the force that's going to keep that blood flowing through your body at a set rate. If we don't have a high enough blood pressure, if that force doesn't continually push the blood through our bodies, we're not going to be getting blood to our tissues, which means they're not going to be getting oxygen, which means they're not going to be functioning properly. They won't be able to do cellular respiration and get all that energy that they need. So there's a systolic pressure and a diastolic pressure that we talk about. Systolic refers to the pressure in the arteries when the ventricles are contracting. It's the peak amount of pressure that's going to be found inside your veins. It's usually the top number when a doctor gives you your blood pressure. And then you have diastolic pressure. This is the pressure where the ventricles are relaxing. It's going to be the bottom number of that blood pressure that your doctor gives you. So what affects our blood pressure? Our brain, obviously. If I'm experiencing a fight or flight incident, my brain is actually going to be setting off signals and releasing chemicals in my body that causes my blood vessels to what we call dilate. They're going to get bigger. So this is the normal, and this is a dilated blood vessel. And you can see it's a lot more open than the original. I want more blood flowing through my veins so I can get more oxygen to my cells and I can respond at the peak level possible so I can evade whatever is scaring me. Temperature can also affect the size of your vessels. When it's really cold, you might get constricted arteries, particularly in your capillaries. You'll see that in your hands and in your ears and in your nose, so you won't have as great of blood flow to those areas because we're trying to restrict the blood flow to all my important organs like my heart and my brain and all of my internal organs. We also have certain factors that our kidneys create, and those are going to regulate our blood volume. Remember, our kidneys are there to filter out toxins from our blood and from the liquid inside our bodies. So more water in your blood means a higher blood pressure. Less water in your blood means a lower blood pressure. When we have our arteries get smaller, it's called vasoconstriction. I'm constricting my blood vessel. When my arteries get larger, this is going to be a vasodilation. They're dilating or getting bigger. In this case of vasodilation, my BP is going to, made a mistake there. I'm going to see my BP decrease. With vasoconstriction, we see an increase in our blood pressure. It takes a lot more effort to push blood through a tighter opening than it does to press the same amount of liquid through a larger opening. Now, your blood pressure is going to vary throughout your lifetime, but there's a couple times where it's not really functioning properly, such as with chronic hypertension. Hyper means above, so this is where our blood pressure is above what it's supposed to be. And it's not just a high blood pressure when I'm working out, it's going to be a high blood pressure even when I'm at rest. And doctors use the number 140/90 as the clinical measure to say this is high blood pressure. It causes your heart to work harder, it will strain your muscle, it'll damage the heart, and you can end up actually getting your heart to a point where it gives out. So chronic hypertension is often called the silent killer, because your heart is working harder and harder behind the scenes, and eventually it just says, I give up. You can also have the opposite, hypotension, where you have a really, really low blood pressure. And this is where you have a systolic pressure of less than 100. And this actually can happen if you exercise a lot. Now, not during the exercise, but the better you are, the more in shape you are, the lower your blood pressure is going to be, because your heart is operating at a stronger capacity. That muscle actually gets stronger and it can pump out blood more efficiently, so we don't have to increase our cardiac output as much, and we're going to end up having a lower blood pressure as a result. You also have a temporary kind of low blood pressure. We see this often in older patients. So you'll have orthostatic hypotension. This is where you'll be sitting for a long period of time, and when you go to stand up, your vessels can't accommodate that change as quickly as they used to be able to. They can't get dilated or constricted fast enough, so you'll actually have a momentary period where blood flow gets cut off to a part of your body, most commonly like your brain, and you pass out for a minute. It's something that is only really dangerous if it's hiding an underlying condition or if you fall and hurt yourself as a result. So how do we measure our blood pressure? The most common method, you'll probably have experienced it with your doctor, is this auscultatory method, where you're actually listening to the blood pressure in your veins or in your arteries with a stethoscope. And they'll put this sphygmomanometer around your arm, and they will actually use that as the guide for the pressure amount while they're listening to your heart or to your vessels. Basically, they're going to pump that arm cuff full of air, and it's going to squeeze your arm and actually block blood flow through that artery. Slowly, they're going to drain the pressure out of that cuff. When the blood flow is completely blocked, you won't be able to hear a pulse because no blood is actually flowing through that artery. As you release the pressure slowly, the blood will start to slowly leak back into that artery, and when it's high enough that we can detect the blood pressure, the sound of the pulse going through your artery, that's going to be your systolic pressure. What doctors will do is as soon as they hear that particular sound, they're going to make a mark of where it occurred on the sphygmomanometer, and they're going to say, okay, so the top number was like 122. And then they're going to keep listening until they can no longer hear the thump of that pulse. And at that moment, they're going to look back up at the sphygmomanometer and say, oh, that's my diastolic pressure. It takes a lot of practice, and it's a little bit tricky when you first start out, which is why technology is great, because now we have computers that do this for us. So we're going to end on an interesting difference in circulation. When we're normally circulating our blood, the arteries carry oxygen-rich blood away from the heart. The veins carry deoxygenated blood back to the heart. Babies, they have to get their oxygen somehow, and they don't breathe air, so they get all of their oxygen from their mother. And this is why when we talked about our blood PowerPoint, you see that pregnant moms can sometimes have elevated numbers of red blood cells to accommodate for that extra demand of oxygen that their baby is asking of them. So the mother's blood gets taken to the placenta, and the placenta has the umbilical cord attached to it and to the baby. Now, the umbilical vein is going to carry the oxygen-rich blood to the baby away from the mom. So this is different than normal circulation. The umbilical arteries carry the deoxygenated blood back to the mom from the baby. Now, really, the blood never mixes. The mother's blood never fully mixes with the baby's blood. The placenta is going to be the go-between, kind of like a blood-baby barrier, you can say. And that's where we're going to end it today. If you have any questions, let me know.